you so much for joining us. No, that's good. Thank you so much for joining us. My name is Claire McEwen, and as Satori said, I am joined with our colleagues Cash Harrison and Sydney Walker. We are from the Public Health Preparedness Program within the Division of Disease Control at the Philadelphia Department of Public Health. It's a mouthful, but we'll be presenting our work to increase access for people experiencing homelessness and people who use drugs in Philadelphia, and how MRC volunteers help to make this important work possible. All right. So tonight we'll just be discussing how our team was developed, how we've evolved, our current objectives. We'll also discuss what volunteers can expect when they're deployed with our team. Sydney will be giving a brief overview of vaccines that we offer, preparation and precautions, and then Cash will go over some of our data from the last 2 years and how to get involved. All right, just to give everyone an idea of the number of people experiencing homelessness in Philly, on a single night in 2022, an estimated 4,400 people were experiencing homelessness. This number comes from the Office of Homeless Services point in time count that happens every year as a part of HUD funding requirements. And it encompasses folks who are within the homeless services, within various homeless services programs throughout the city, and also people who are staying outside in transportation centers, parks, and cars. And as I'm sure you can imagine, this is very difficult data to collect. So that's why we use the point in time count as one of our metrics. All right, so I'd like to go through a little bit of background of our team by starting out with the COVID-19 vaccine rollout. So people experiencing homelessness and people living in congregate settings were prioritized very early on in the rollout, and it's because of a number of reasons. So people experiencing homelessness may have a higher risk of severe COVID-19 disease due to a number of things, such as underlying health conditions, lack of access to consistent health care, transient living, possible substance use, living in congregate settings. Also, in this population, there does tend to be a history of stigmatization within the healthcare system that has led to a lot of distrust. And so I am sure many of you are aware that whether it's from volunteering at clinics or going through the vaccination process yourself, but many of the early vaccine clinics were mass community clinics. And we saw very early on that the needs of people experiencing homelessness were not being met with this clinic model. So there were a number of barriers identified very early on. So for example, these clinics had very strict appointment requirements where appointments were very difficult to get early on. They also, in the very beginning, required proof of residency. If you don't have an address, it's really difficult to prove your residency in Philadelphia. And then people experiencing homelessness may have a lot of competing priorities. So spending time to travel to a vaccination clinic, waiting in line, going through that process can be very difficult, especially when day-to-day life can be so hectic. We also saw a lot of vaccine distrust and misinformation within this community, so it required a more direct approach. All right, so in order to address these barriers, we worked with the Office of Homeless Services, the Department of Behavioral Health and Intellectual Disability Services, the Substance Use Prevention and Harm Reduction Division, and many other community programs servicing people experiencing homelessness to develop a mobile team that could meet the needs of this population that we saw. And so we started off by surveying homeless service programs, safe havens, recovery homes, community-based organizations to determine the most vulnerable sites to prioritize our efforts early on. And we worked with these partners and the Acute Communicable Disease Program to identify sites that were priority as needs changed, and then as the virus spread, and as different needs came up in different organizations. And so to do this work, we used a mobile team model to meet the needs to meet people where they were. And it's a best practice that we used during the hepatitis A outbreak in 2019, and we were able to build upon that model for COVID-19 vaccines. And so we developed a small team that was able to bring vaccines to the sites, and then we even began holding vaccine clinics outside where people experiencing homelessness and people who use drugs congregate to minimize more barriers to access. To increase our engagement, we worked with partners and other programs to offer wound care, STD testing. We worked with community organizations and community harm reduction organizations during their outreach events to hold clinics. And then we also provided outreach items regardless of vaccine interest. And then the Vaccine Ambassador program was developed midway through the vaccine rollout to train individuals with lived experience of homelessness to discuss vaccination and the importance of vaccination with their peers, and also provide incentives like gift cards for people who got vaccinated. So that was another important aspect of this, and really was trying to tackle that vaccine misinformation that we saw. So our current team is made up of PDPH DDC employees. We're currently focusing on sites in Center City and Kensington, and we mostly work with unsheltered populations and folks that don't necessarily have day-to-day access or at least a relationship with other sites. So trying to bring vaccine out into the community more. And we do hold occasional clinics and shelters for disease prevention during outbreaks, and we work with our partners in acute communicable disease. They're the ones that do the testing and surveillance of disease outbreaks and infection control. So we kind of look to them to see where we're needed. But we do try to get shelter sites linked up with pharmacies at this time for that more routine COVID-19 booster. And like I said, we work more with unsheltered populations at this time, just because we're seeing that's where the need is. And we really rely heavily on MRC volunteers to help us meet folks where they are. So just a quick shout out to you guys. You really are important. So just for anyone who hasn't come out with us before and doesn't know what to expect, these are some photos of our setups out on the sidewalks in Kensington. Our clinics typically run for about 4 hours. That includes setup and cleanup. And the times really vary depending on location. We really look to our partner organizations if we're working with anyone to see when the best time to reach people would be. That does tend to usually be over lunchtime during the week, because that's when a lot of services are being offered. And then we bring outreach and harm reduction supplies, like I mentioned earlier, that we give out regardless of vaccination status. You can see a picture to the right here of just some of the things that we have offered recently, but we offer these based on funding and what we're able to purchase, and we try to make them weather appropriate. So we give out emergency blankets, hand warmers, gloves and hats in the winter, and other harm reduction supplies such as Narcan, fentanyl test strips. We have COVID-19 test kits and hand sanitizer, all of that stuff that we give out regardless of if people are getting vaccinated or not. We use it as a way to engage people and try to build trust week after week. Folks know that they can just come up and ask questions. We try to have a regular presence. And we try to have a low to no barrier clinic model. So that means that we don't require any appointments, no paperwork, no identification, insurance, or even proof of prior vaccinations are required. So if folks aren't sure whether they've been vaccinated before, we can look them up in the Philly vaccine database. If they've been vaccinated in Philly, we'll be able to look them up. But if they haven't been vaccinated in Philly, we try to probe them. We ask questions about what was the weather like when you got vaccinated, things like that, to try to get a better understanding of whether someone is due for a new vaccine or not. And then our staffing setup, we try to have 2 vaccinators and 2 data collectors. The data collectors do all of the screening for allergies and contraindications. They're also responsible for recording the vaccines, giving folks their documentation. We try to have 1 outreach or line staff, which is usually a PDPH employee, to screen folks ahead of time, answer vaccine related questions, and try to engage individuals that are passing by. And then a vaccine manager, which is usually Cash, who handles the vaccine coolers, but also will distribute doses as needed. So prior to deployment, we just like folks to be aware of some safety precautions. So being prepared for the weather, like I said, we are usually outside. And then wearing closed-toed shoes. We are often in areas where there are exposed needles and other hazards on the ground. Water, snacks, the usual. Giving yourself time to find parking, it can be difficult, but don't stress out. Call us if you ever have any difficulty with this, because it's important, number one, that you're safe and not walking alone. So we're always there to make sure that you have a buddy with you. And then we also do recommend folks to complete a Narcan training before deployment. It's not required, but definitely recommended. All of our staff has been trained and has used Narcan a number of times out in the field. So we wouldn't be only relying on you, but it's just a good thing to be aware of. So we have something linked in this slide. And then at the end of the slides, we have a few other resources as well, if that's something that you're interested in. Like I said, always traveling in pairs. I think that's just good practice in any area that you're not familiar with. And I'm going to pass it on to Sydney, who's going to talk about the number of vaccines that we offer. Like I said, we do COVID-19 vaccines, but we have added other routine vaccines just to increase engagement and lessen barriers for the populations that we're serving.
Good evening, everyone. Again, my name is Sydney Walker. I'm a COVID-19 nurse and preparedness planner for the Immunizations and Bioterrorism and Public Health Preparedness programs. And like Claire said, today I'm going to talk to you guys about the vaccines that we offer. And I'm also going to talk about contraindications and ways for you to not have to memorize all this that I'm going to give you. But the vaccine products that we use they include the COVID-19. Oh, yes. And like Satori said in the chat, I'm also the MRC medical lead. So we use the COVID-19 monovalent product for Pfizer and Moderna. We also have the COVID-19 bivalent, and it says in Moderna 12 plus only for the bivalent booster. But what I do want to point out here is on this slide, it does have 12 plus for both of these COVID-19 vaccines. And that's just because for the COVID-19 vaccine, we will vaccinate people 12 years and older. But for all the other ones, the people that we serve have to be 18 and older to receive them. And those include hepatitis A vaccine, hepatitis B, influenza, and Mpox. Okay, so these are the doses and intervals along with the products. So the Pfizer monovalent product is a 0.3 milliliter dose, and it comes in a multi-dose vial. With the Pfizer multi-dose vial, you have to make sure that you invert 10 times. And then prior to actually drawing up the vaccine, the interval is 2 doses, 3 to 8 weeks apart. Then we have the Moderna monovalent, which is a 0.5 multi-dose vial. This one you actually have to swirl before you take out your first dose. And it's a 2-dose series, 4 to 8 weeks apart. The Moderna bivalent dose is a 0.5 milliliter dose, and it's given 2 months after someone's received their last dose. We have the Jynneos. The Jynneos vaccine can be administered intradermally, but we do only do it sub-Q. And so right there in your bat wing, that dose, you're going to use this, it's a single dose vial at that point. You're going to use the full 0.5 that's inside of that vial. To prep this vaccine, you just have to make sure that that is also swirled for 30 seconds, 2 doses, 28 days apart. We do kind of fluctuate between Flucelvax and Fluvival for our flu vaccine. It's really all dependent on funding for that year, but that is a 0.5 milliliter dose that comes in a pre-filled syringe. So you don't have to worry about drawing up and prepping this vaccine so much. All you really have to do is shake this vaccine. It's 1 dose annually, and we do give it, throughout the year. So then there's Havrix, which is our hepatitis A vaccine. It's a 1 milliliter dose, also coming in a pre-filled syringe. Just have to worry about shaking it. And then it's 1 dose with 1 booster in 6 to 12 months. A lot of the people that we see might have had a hepatitis A vaccine in the initial hepatitis A outbreak a few years ago. That's okay. We will still give them that booster dose. And it doesn't really matter how long. And even some people aren't sure if they've had a second dose or if they completed that series or if they've even had it at all. But what's great about Havrix is it does not hurt to get an additional dose. It's probably the safest just to make sure that that person really is protected. And then we have the HEPLISAV-B. It's a 0.5 milliliter pre-filled syringe. Again, all you have to do is shake it, very easy. And of course, attach the needles. And it's 2 doses, 1 month apart. And so some of the contraindications for the COVID-19 vaccines, for both of them, it's really an absolute contraindication would be severe allergic reaction to any component of the vaccine. And then we want to make sure that we caution if someone's had myocarditis or pericarditis 7 days following their second dose of the vaccine. Then we have Jynneos, which is indicated for Mpox. The absolute contraindications are anaphylaxis to chicken, eggs, or egg protein, gentamicin, ciprofloxacin, neomycin, streptomycin, levofloxacin, and then previous dose of Jynneos. And then also, we're not vaccinating people with Jynneos if they've had a previous history of an Mpox infection, just because at this point, we're kind of assuming that they have some type of immunity, and this vaccine is a little bit hard to come by. And so we would rather vaccinate those who have not had a previous documented Mpox infection. So then for the influenza vaccine, they kind of differ just a bit, but we still kind of follow the general contraindications and cautions just to make sure that we're covering all of our bases. So we want to make sure that someone does not have anaphylaxis to egg protein or any anaphylaxis following any previous dose of any influenza vaccine. We do want to make sure that we caution if anyone's indicated Guillain-Barré syndrome within 6 weeks of a prior influenza vaccine, and we just want to weigh the risks and benefits. Of course, it's pretty rare, but if someone might be at very high risk, or you can essentially use your clinical judgment that if someone is at high risk for severe disease from the flu, that person might still be able to get a flu vaccine that day. But if you don't know, if you're not sure, Claire or someone on the homeless outreach team will contact myself or Dr. Shara Epstein, who's she's our medical director, and will help you through that decision making. Then there's the hepatitis B vaccine, or HEPLISAV-B. And contraindication to this vaccine is anaphylaxis to yeast, Baker's yeast, or any previous dose of HEPLISAV-B. And we also don't want to use this vaccine in anyone who indicates that they're pregnant, just because this vaccine hasn't really been studied robustly in pregnant people. If you do come upon someone during your time with us that they've indicated that they're pregnant and they did get a HEPLISAV-B vaccine during their pregnancy, that we can maybe sign them up for a program with the CDC so they can track their progress and the baby's progress after they're born. And so then there's hepatitis A vaccine. The contraindication to this is anaphylaxis to latex. This vaccine, the stopper is latex, and so we want to make sure that we don't expose someone who does have anaphylaxis to latex to this stopper. Also neomycin or any previous dose of Habrix. And so, do we have any more? So yeah, okay, so I know I just hit you guys with a lot of contraindications, cautions, dosing, how to prep the vaccine, but you really don't have to worry about memorizing all of that. Of course, I would highly encourage everyone to look up these vaccines before your deployment so that you're a bit more familiar with them and you're able to make sound decisions while you're out in the field. But we do have paperwork for you guys to read over while you're there, and then just a quick cheat sheet so you can see everything very concise. And we'll show you that in an upcoming slide. And so this is the checklist that the data collectors will typically use when you're outside. It screens for everything that the person would be getting that day. So you don't have to worry about going through the checklist, the screening checklist for contraindications, but I would just become familiar with this. Typically, when we're outside, I like to listen to the data collector as they're asking the questions. And just in case something's missed or I just have additional questions, I will ask more questions regarding their contraindications. But our data collectors are great, and they usually do cover everything very thoroughly. And so this is that cheat sheet that I was kind of telling you about. And it's great because we do have many products that we're offering, right? But this paper, the packet will show what the vaccine looks like. And then it will list the indication, the vaccine prep, the dose, the administration, like the route of administration, the interval, and contraindications and cautions. So you don't have to memorize everything. And you can even keep this packet right next to you. So if you need to just refer right back to it during your time with us, that is totally fine. We also have a medical standing order, and then a standard operating procedure on site that you can also refer to when you're with us. All right, so I'm going to now pass this over to Cash.
Good evening. My name is Cash Harrison, and I'm the at-risk population specialist for the homeless outreach team. I support many of the efforts of the team, and as Claire stated earlier, I do a lot of the vaccine management on site. And during this part, I will go over the numbers and data for our team since March of 2021 when we first started, and then we'll answer questions, and then we'll conclude this training.
Cash, I'm so sorry.
Yes.
I forgot to ask, and you just reminded me, does anyone have any questions after I just went over all that vaccine information? So sorry, Cash.
No worries, no worries. Please ask.
And if you don't feel comfortable speaking out loud, please feel free to put any questions in the chat, and I'll try to address them while Cash speaks. But I do want to give someone just a moment to indicate if they have any questions before we continue.
I apologize for the background noise. Colleen did ask a question. Colleen, I'll email you separately and I'll respond to that specific question of yours.
All right, so if there are no vaccine related questions, I will just look in the chat and see if you guys have any questions in there. Thank you so much. And sorry, Cash, please continue.
No worries. And thank you, Sydney. So the following data I'll be presenting on will be data that we collected since March of 2021 when we first started until January of 2023. So as you can see on the data, we've hosted over 180 clinics throughout the city. We've administered over 5,200 vaccines, and we've clocked over 300 hours for Medical Reserve Corps volunteers. And I truly do mean it, that we wouldn't be able to do the work we do without the efforts of the Medical Reserve Corps volunteers. And on top of that, your efforts have saved over $17,000. And also, if you see to the left, this is everywhere where we've hosted clinics. You can see that most of the clinics that we've hosted is in the lower Northeast in the Kensington region and Center City. But what we do as the homeless outreach team is that we will go anywhere to meet people where they're at. So whether it's in Kensington, Center City, or it could be in any type of shelter in any part of the city. So this is the data of the vaccines that our team has administered. And you can see that the majority of the vaccines that we have administered have been COVID-19 vaccines. But after that, it's hepatitis A vaccines. So a lot of the people that we may see, sometimes they might be finishing up their series for hepatitis A, from the 2019 outbreak. And also it's not also one way that hepatitis A could be spread, can be spread through the sharing of needles, and the populations that we see could be susceptible to that. So we offer that vaccine as a means of protection, especially in the Kensington community. And you can see we also offer Hep B, pneumococcal, as well as Mpox and influenza. But we might be slowing down on influenza as the flu season comes to an end. And next slide. So beginning in January of 2022, we started a red cap survey to ask very basic questions to the patients that we see, asking questions such as demographics, health insurance status, and housing status. And one of the reasons why we ask these questions is so we can have an understanding of the populations that we are serving. And we also collect the demographic information to try and see that we're trying to reach as many people throughout the Philadelphia's homeless communities. So you can see we predominantly see people who are either Black or African American, as well as white. So one thing I want to bring up is that one time I had a friend who asked me, Cash, from your experience, where do you think is the most diverse neighborhood in Philadelphia is? And I mentioned that I think one of the most diverse neighborhoods that I've been in is probably the Kensington neighborhood, because addiction does not discriminate. And it doesn't discriminate whether you're Black or white, whether you're educated or uneducated, or whether you're poor or rich. This is something that affects everyone. And this is something, to definitely think about when we go out into these communities. Next. So in this red cap survey, we will also ask about a individual's housing status. So you can see in the first 4 rows, those are answers to some form of someone who is unstably housed and experiencing homelessness. And then at the bottom, you see people who are stably housed at roughly 42%. So I just want to let you know that the data that we collect here is qualitative and it can be open to interpretation. But also we do serve people who work in some of the facilities that we partner with, and employees who work with people who are experiencing homelessness. Next. And last but not least, we also ask about people's health insurance status, so we can have an understanding of whether they have health insurance or not. So if we refer them to services, and they ask for insurance, then we know, at least we have an understanding that the majority of the people, 76%, have government issued health insurance. So oftentimes when people say that they have government issued insurance, they might say that I have Medicaid, or the one common plan I've heard is health partner plans. And then some people we see do have private insurance, and unfortunately there are people that we see out there who don't have health insurance at all. So sometimes when they come to our table, that we might be the only healthcare practitioners that they might interact with. And next. So before I say my big thank you, one thing I just want to mention about the survey is that a data collector so if you're working as a nurse at our clinics, the data collector that you're paired with will ask the survey questions. So if you're a nurse, you won't have to ask these questions. And finally, I want to say thank you to our MRC volunteers. And I can't say this enough, that we truly can't do this work as effectively as we do without your efforts. So thank you very much. And I look forward to working with all you out in the field. And if you're interested in enjoying this important work, feel free to email mrc@philo.gov.
Thanks, Cash. Before we open it up again to questions, I do just want to note two things, that all of these vaccines can be administered together, and we do administer up to 4 vaccines per patient, so 2 in each arm. And then the other thing I think would be good to point out is that the majority of folks that we see do have health insurance. But with a lot of these vaccines, and possibly even in the future with COVID-19 vaccines, there is a copay associated with getting vaccinated at a pharmacy. And so for this population, it's really important that we're offering all of these other routine vaccines, even though people do have health insurance. They can come with a pretty costly copay for some folks. So yeah, with that, I just would love to open it up to any questions. And also, this is our contact information here. So if you have any questions after the training, feel free to reach out.
Thank you all so very much. Again, I really appreciate you providing this training for us and all the information that you all presented on. As always, you guys, like Claire mentioned, and Cash and Sydney, you can always reach out to them specifically if you have questions about anything they presented on today. If you're interested in this type of deployment, we're happy to have you. I'm more than happy to schedule you. Just so please reach out to mrc@philo.gov. I'm gonna insert a little plug here. We do need volunteers for, I believe it's March 14th, right, Claire? I think so.
Yes, I believe so.
Okay. And so if you're interested, please let me know. We do have, on occasion, there are some roles for non-clinical volunteers or non-licensed clinical volunteers, or just even health professional students, nursing students. If you're interested in that volunteer opportunity, please contact me. I will try to find you an opportunity. It kind of pops up, every now and then. But we are, very interested in getting more clinical volunteers involved in the rotation. We do have a core group of volunteers who have been doing this for 2.5 years now. So shout out to Julie and Pat and Sue and Cindy. Oh my gosh, Sydney. There's too many C's. I'm sorry. To Cindy. I can't even say it now. I'm sorry. But thank you all to to the ones who have been, very supportive throughout this entire process. As each of my colleagues have mentioned, we cannot do this work as effectively as we can without your support. So we greatly appreciate it. And if you have any specific questions, like I said, reach out to me. This training will again be posted on our Philadelphia MRC YouTube page. And there is also, we did do a Narcan and a fentanyl testing strip training a few months ago. That's also linked on our YouTube page as well. But if you are interested in any more information about that specifically, again, please reach out to me and I'd be happy to give you any information that I can. Ignore my dog. I apologize. He's in need of attention. Aside from that, thank you all very much for attending this training this evening. We appreciate your time and your attention. And as always, it's a pleasure to have you as an MRC volunteer, and we hope to see you in the future. So I'll hang out, if there's any questions. And yeah, thank you so much. I'm just going to check the chat. I feel like there's a few things that popped up. Yeah, even if you are already trained in Narcan or fentanyl testing strip training, it does not hurt to, kind of revisit and refresh that information. Thank you, Sydney, for linking that. I appreciate that.
Answering Anne, it really depends. Clients can be like difficult, have not so great memory of their vaccine history. So that's really when we do those probing questions about the season of their vaccine, about the length of time of their last vaccine. And like Sydney said, some of these vaccines, it's more important for them to get a double dose than it is for them to not have anything at all. So if they really, really don't remember and there's absolutely no way for us to look it up, we kind of weigh the risks and benefits for that as well. We do track in the Philadelphia immunizations record system, Philovax, and so anyone who gets vaccinated in Philly should be in this system, but it's not always the case. Providers aren't always the best at entering their series, so that can cause difficulties. But that's how we track where people are in their series. And then we also write them cards, whether it's COVID cards or their the yellow vaccine cards as well.
Okay, I think we've answered everyone's questions. So thank you guys so much again for your time. Colleen, I will definitely reach out to you and give you more information about your specific deployment. And just for in the future, if you guys do see emails from me about certain deployments regarding the homeless outreach and at-risk populations team, if there's ever anything that's not clear, because I do send out tons of emails a day, please just reach out to me. I would happily clarify anything for you as I can. So, and sometimes I post these opportunities as well on our Philadelphia MRC LinkedIn page. I'm going to plug that in there as well for you guys to follow us. A lot of updates, volunteer highlights, and a lot of relevant information is posted on there as well. So thank you. We really do appreciate all of you so much. I mean, you guys just dedicate your time and your services out of the kindness of your heart. So I couldn't have asked, for a better group of volunteers than you all. So you guys are just amazing. I brag about you guys all the time. Okay. I think that's it. Thank you so much. I think we're going to call it an evening. And you all know, how to contact us going forward. So thank you again. I hope everyone enjoys the rest of their evening, and you'll hear more from us soon. So more to come. This work is going to continue, so it's not going to stop here. All right. Thanks, everybody. Have a great evening.